So I changed this a little bit from last year, just to be a little bit more coherent and to cover all of the topics. So I do apologize for the delay. Some of the slides may be familiar to some of you, but I added just a little bit of stuff, and hopefully we'll try to catch all of the ABSITE related questions. All right, so abdominal transplantation, I don't think I need to explain what exactly that means, but basically it's liver, kidney, and pancreas transplantation, to a lesser degree, intestinal transplantation, which is a small part of the overall abdominal transplantation, but primarily we think of liver, kidney, and pancreas as the main organs. So this talk will basically cover indications, surgical approach, and some technical considerations for liver, kidney, and pancreas, cover some immunobiology of organ transplantation so we can kind of get a general overview of what is key in terms of this next topic, which is immunosuppression, and then discuss some of the consequences of transplantation, both immunologic, such as rejection, and then the side effects of immunosuppression, including infectious and to some degree malignancy-related complications. All right, so the first thing we'll talk about is liver transplantation. So liver transplantation, about 8,000 or 9,000 liver transplants are done in the United States each year. It is the only known cure for what we call chronic decompensated liver disease. Chronic decompensated liver disease it constitutes the largest indication for liver transplantation. In that category, the components are usually about 40% of patients will suffer from alcoholic liver disease. That's been pretty constant since the advent of liver transplantation. What's new over the last decade is the increasing incidence of metabolic-associated steatohepatitis, previously called NASH, which now constitutes about 30 to 35%. Hep C, because of the advent of effective antivirals, has really fallen in terms of its cause of chronic decompensated liver disease. So probably now constitutes 20% or less. Hepatitis B in the United States is a pretty small fraction, maybe 5 to 10%. Primary sclerosing cholangitis, which in adults constitutes the largest biliary cause, again, about 5 or 10%. And then there are some other scattered either congenital issues that come into adulthood. But by and large, these compose the major reasons people get transplanted in the United States, or the major reason that people have decompensated liver disease. And we'll define that in the next sort of panel here. There is a small percentage, about 5% or less, of patients who suffer from what we call fulminant liver disease, which is liver disease in which there is no previous underlying chronic component. And classically, those are associated with acute alcoholic or acute intoxicants to the liver, Tylenol, acute Budd-Chiari, which is acute outflow obstruction, infection, which is pretty low. We don't really see that much in the United States. Acute on chronic autoimmune. I should have noted here Wilson's disease. So Wilson's disease might be a question on the test for subacute or fulminant hepatitis, classic Kaiser-Fleischer rings, if that's on the exam. Aflatoxin, which is a mushroom-induced acute liver failure, which is commonly seen actually on the West Coast of the United States. And then to some degree, postnatal or perinatal HELP syndrome, which is elevated liver enzymes, low platelets, a sort of a syndrome equivalent of thrombotic thrombocytopenic purpura. So, but really, Tylenol probably is the biggest cause of fulminant, followed by probably Wilson's disease and autoimmune hepatitis, and then to a lesser degree, aflatoxin and Budd-Chiari. There's also malignancy as a reason to transplant folks. The most likely malignancy that would be transplanted is hepatocellular carcinoma. Again, that constitutes probably 90 to 95% of all patients who are transplanted on the basis of malignancy. Overall, about 30% of all chronic liver disease patients may develop a hepatocellular carcinoma. There are other indications for malignancy-related indications for liver transplantation. These include recently non-resectable colorectal metastases, endocrine neoplasms limited to the liver, and cholangiocarcinoma, which we can talk about, but generally constitutes cholangiocarcinoma that is extrahepatic between the bifurcation and the cystic duct and less than 2 centimeters in size. So, and then we'll talk a little bit about the Milan criteria in the next one. Pediatric reasons for transplant are primarily congenital, of course. Biliary atresia is about 70 to 80% of all reason that pediatric patients get transplanted. About 10% is hepatoblastoma. And then after that, the remaining probably 10% is other congenital reasons, biliary cystic intrahepatic liver disease, familial cholestasis syndromes like PFIC 1 and 2, and urea cycle defects. Again, these constitute a very small percentage overall. So how do we determine who needs a liver transplant? So primarily in the adult world, we use the model for end-stage liver disease. Well, what does that reflect? So the model for end-stage liver disease was developed to address 90-day mortality after acute alcoholic hepatitis, but has since gained broader use in predicting 90-day mortality for anybody who has liver disease. So the MELD score is composed of, there are modifications now. There are two modifications. One is the MELD sodium, and then most recently is called MELD 3.0. So what do these constitute? So serum sodium, serum creatinine, INR, and bilirubin for MELD sodium. And for MELD 3.0, it includes albumin and gender, because there was a sense that albumin reflected performance status, and there was a skewing of the MELD score toward male patients, leading to disparities in liver transplantation among female patients. Basically, the MELD score helps predict 90-day mortality. So if your MELD score is low, your 90-day mortality is low, and it doesn't make sense to get a liver transplant because the 90-day mortality for a liver transplant is about 2 to 3% nationwide. So on average, that means that patients who have MELD scores classically 14 or below usually really don't get transplanted unless they have another reason, such as a malignancy like hepatocellular carcinoma. Whereas patients who have a MELD score of 15 or above classically have been associated with improved long-term survival. So that's the MELD score. There is something for pediatric patients for under the age of 12 called the PELD score. It includes serum sodium, bilirubin, albumin, creatinine, INR, but also includes height and weight. So patients who suffer from chronic end-stage organ disease, particularly liver disease, will have disparities in terms of their overall height or weight or growth charts as compared to their non-liver disease compatriots or cohort. And so that's calculated in the PELD score. I don't recall there being a lot of questions about PELD on the ABSITE, but that's there if it does show up. All right, and remember, it's for under 12. So if you're 12 and over, everybody goes to the MELD score at that point. All right, a brief word about Milan. So what is Milan? Milan is basically a sort of catch-all for the criteria developed for hepatocellular carcinoma that can be benefited by doing a liver transplant, meaning patients live longer and do better with a liver transplant as opposed to other therapies when they have hepatocellular carcinoma. It is based on the concept of size and numeracy of lesions. So Milan basically is you have to have one lesion of cancer 5 centimeters or less, or you can have more than one lesion, but no one lesion can be more than 3 centimeters, and the total size of all 3 lesions has to be 9 centimeters or under. Why do we pick Milan? The retrospective and then prospective data about this suggests that the best survivals for patients, best 5-year survival for patients after liver transplant with hepatocellular carcinoma is for those who fall within the Milan criteria. That also is extended to some degree in patients who have endocrine neoplasm that's metastatic to the liver only, and now with these new protocols for colorectal cancer. All right. Okay, so what are the contraindications? The contraindications you'll notice for almost all the diseases are pretty much the same. So for liver transplantation, it's severe cardiopulmonary disease, particularly right heart failure and liver patients. So why is that? Well, when you put in a new liver, they get a sudden rush of blood flow through the liver from the portal mesenteric circulation. If they have right heart problems, they don't do very well. Their right heart doesn't work. So patients who have right heart failure with a RVSP of 35 millimeters of mercury or greater, or a mean pulmonary artery pressure of 40 or greater, are really not considered candidates until that's corrected. If you have severe coronary artery disease, that's also a contraindication because you're unlikely to tolerate the pressure changes or fluid shifts within a transplant. Certainly extrahepatic malignancy or malignancy outside of Milan. Poor performance status, so this is kind of a catch-all of people who are nutritionally depleted, are very frail. If they're severely critically ill, so a lot of programs will not transplant patients if they're intubated or on pressor support. And then there are psychosocial contraindications. Sorry, malignancy ended up in there somehow. But so patients who have active substance abuse, who have no psychosocial support, or who have psychosocial or psychopathology, such as severe depression, suicidal ideation. So that often comes into case in things like fulminant liver failure, where you're trying to determine if somebody, who ingested Tylenol is, in a place where they can recover psychologically. All right, next. So what are the technical considerations of liver transplantation? So 95% of liver transplants in the United States are what we call deceased donors, meaning that they come from people who die and then donate usually a whole liver. About 5% are living donors. So we can think about the technical issues in liver transplantation basically as follows: inflow or outflow, inflow, and the bile duct, right? That's basically the three major categories. So what is the outflow? So the outflow of the liver is the hepatic veins into the vena cava. And so the two classic ways in which we can reconstruct the outflow in a liver transplant is either use the vena cava that comes along with the liver allograft. So that's the first sort of this diagram here, which is called caval interposition. So basically, you cut the old liver out, including the suprahepatic and infrahepatic cava. So the patient is interrupted venous flow. And then you sew the new liver in by sewing the suprahepatic and infrahepatic cava to the recipient. So this is called caval interposition. Now, the thought was that this caused a lot of hemodynamic instability. So maybe we can get away with just using the hepatic veins as outflow. So that's called piggyback, where instead of replacing the cava, all you do is you use the outflow tract of the liver, its hepatic veins and the suprahepatic cava, and you sew that to the outflow tract of the recipient, the suprahepatic cava of the recipient, or even to the side of the vena cava. So that's the outflow. All right. What's the inflow? So the inflow is the hepatic artery and the portal vein, right? So usually the hepatic artery of the donor, whatever anatomy there is, usually gets sewn to the hepatic artery of the recipient. The portal vein of the donor usually gets sewn to the portal vein of the recipient. Now, what are the exceptions to that? So you may have somebody who has portal vein thrombosis. So about 5% of all end-stage liver disease patients may have portal vein thrombosis. Some patients may have cavernous transformation, sometimes a little bit more common in kids. You can use conduits from the superior mesenteric vein into the liver to provide inflow. There are other more less commonly used but talked about inflow strategies. I don't think they appear on the ABSITE. So, I mean, I'm happy to answer questions about those, but I don't think they're relevant. For the bile duct, primarily the bile duct is connected duct to duct. So we take the duct of the donor and we put it to the duct of the recipient. That's called duct to duct. It allows us to access the bile duct using the endoluminal techniques such as ERCP without having to do more complicated procedures. The bailout procedure for reconstruction of the bile duct is a Roux-en-Y hepatocogaginostomy. So what are the complication rates? So in general, the complication rates for outflow are pretty low, less than 1%. Either caval thrombosis or narrowing can be corrected usually by stenting. Sometimes, but not commonly, requires a revision. Portal inflow, again, not commonly thrombosed. If that happens, you need to correct it surgically. There aren't many non-surgical approaches. If there's chronic stenosis, it might be amenable to what we call a TIPS. Hepatic artery thrombosis is the most likely vascular complication, 1 to 3% post-transplant, and that usually requires revision right away and or retransplantation. The bottom slides depict living donor liver transplant. What I'll basically say about that is that for adults, primarily it's a right lobe graft, and for kids, it's usually left lateral segment graft. All right, so next, kidney transplant. Kidney transplant indications are really quite simple. Basically, anybody with chronic kidney disease, usually an eGFR below 20 mL per minute, that's between chronic kidney disease 4 and 5, or if you're on dialysis. Adult and pediatric, same indications. And the reason there really aren't that many other indications is because we have dialysis. Now, you may say, well, why does that matter then? If you have dialysis, why would you transplant people? Well, again, the mortality on dialysis is much, much greater than it is for patients who have a transplant or have corrected EGFR. So long-term transplantation is better. Now, the causes of ESRD, are pretty much diabetes is about 45% of all adult causes of end-stage renal disease or chronic kidney disease. Hypertension is probably another 10 to 15%. Glomerulonephritis or nephropathies probably constitute 10%. Lupus is another 10%. And then there's other causes like polycystic kidney disease, which may constitute 5%. For kids, it tends to be a little bit more varied, usually congenital. There are lots of congenital syndromes, posterior urethral valves, nephrothesis, I think Oslo-Weber-Rendu syndrome, lots of other individual causes, but they get thrown into the bucket of congenital. So, all right. What are the contraindications? Same contraindications, except with a little bit more. Again, severe cardiopulmonary disease, right heart failure, again, is an issue, not necessarily because there's a reperfusion question, but because patients post-kidney transplant require volume resuscitation, and that may not be possible in patients who have pulmonary hypertension. Coronary artery disease is common, or more common in patients who are on dialysis, particularly those who have diabetes. Again, symptomatic coronary artery disease with a depressed ejection fraction puts them at high risk for perioperative cardiac complications. Peripheral vascular disease is an important consideration in this population. Whether they have rest pain, claudication, it may indicate that they have calcific arterial disease, which may make it a technical contraindication to transplantation, and or their mortality is already very high just by having peripheral vascular disease. Again, active malignancy with a history or malignancy with a history of metastatic disease is a contraindication. Again, poor performance status or severe critical illness, and then psychosocial contraindications. So same things, substance abuse, lack of social support, or psychosocial pathology. All right, so in kidney transplantation, again, always think about in basically the same way as you would any other transplant, which is there's an inflow, and then there's an outflow, and then there's a drainage, right? So inflow here is a renal artery, outflow is a renal vein, and drainage is the transplant ureter. So our considerations for technical considerations are making sure that we have a place to hook each of these things up to. So usually we don't have a lot of venous issues. Patients may have from chronic access, either venous stenosis or thrombosis. I would say that that's less likely than having calcific arterial disease, which affects your common or external iliac artery, where we classically anastomose the renal artery to. And that's usually more likely to be a contraindication for transplantation. For the ureter, we connect it to the bladder. So the bladder has to be available for us to connect it. Occasionally, patients will have had urologic reconstructions that we can hook into, but it's not that common, sometimes a little bit more common in kids. The bottom line with the ureter is that it can be connected to the bladder in 3 different ways. One is through making an anterior opening in the bladder and connecting the ureter that way. That's called a lich. One is by opening the bladder and then tunneling the ureter into the bladder, into the wall. That's called a Ledbetter-Politano. And then the third one is called a single stitch technique, which basically is exactly as it sounds, which is you put a stitch in the one stitch in the ureter and you bring it through the bladder and you tie it down. So what are the things we think about in terms of technical complications? We think about renal artery or renal vein thrombosis, and we think about either ureteral stricture or leak. So for renal artery or renal vein thrombosis, the risk is pretty low. It's under 1%. The risk is actually higher in patients who have higher GFRs. So that's why patients who have GFRs above 20 are generally not considered candidates for kidney transplant because their risk of complications is higher, and their survival doesn't necessarily improve as much. If you get a renal artery thrombosis or renal vein thrombosis, that's an immediate reason to go back to the operating room. So classically on the ABSITE, they may ask you a question, you've done a transplant and you're in the recovery room, all of a sudden you have no urine output. What do you do? Usually the answers are, should you get a renal transplant ultrasound or should you go right back? For the person who's just come out of surgery, the answer usually is you go right back because you want to make sure that there's not been a vascular thrombosis. Other times, or most other times, the diagnostic modality of choice is to do an ultrasound. For classic questions about fluid collections around, let's say, a kidney post-transplant, if that's a question that comes up. So the things are, it can be a lymphocele, so a fluid collection from lymph that's dissected in that area. It can just be a seroma, or it could be a urine leak. So classically, a urine leak will come along with severe pelvic pain, elevated potassium, and a fluid creatinine level from that fluid that's extremely high. So usually that happens about 2 weeks after transplant. All right. Reduction in leaks happens usually because you put a stent in across your anastomosis. All right. So that's kidney transplantation. All right, pancreas transplantation. So pancreas transplantation, the indications are even easier to remember. Basically, you got to have diabetes of some sort, right? So there are 3 approaches to pancreas transplantation. The most common is what we call simultaneous pancreas and kidney transplant. Then there's pancreas after kidney, which is about 5 to 7%, and then pancreas alone, in which I don't know why I wrote chronic kidney disease, but it's about 1 to 3% of those patients. So again, the reason to do pancreas transplant is to reduce mortality, although the reduction in mortality with pancreas transplant is not as clear as it is with the other 2 organ types I talked about. So who gets a simultaneous kidney pancreas transplant or pancreas kidney transplant? If you have type 1 diabetes with renal disease, you're in. If you have type 2 diabetes with renal disease and you have a low BMI and you have an insulin requirement under 1 unit per kilogram, you're in. So why do we consider type 2 diabetes? Technically, those are patients who make insulin, right? Well, there is a group that is considered like type 1.5, who have a reduction in insulin production, have a body type that doesn't fit the classic type 2 diabetes mold, and don't have peripheral insulin resistance. That's why the 1 unit per kilogram sort of requirement is there. And those people can benefit from simultaneous kidney pancreas transplant. Pancreas after kidney is basically if you have type 1 diabetes and develop complications of type 1 diabetes that are non-renal, such as hypoglycemic unawareness, or it may also, pancreas transplant in general may help reverse gastroparesis. It does, and it may slow the progression of other complications such as neuropathy and retinopathy, but for those, it may not reverse them. And then pancreas alone really is for patients who have preserved renal function, but classically have hypoglycemic unawareness. All right. So what are the contraindications? Well, if you don't have diabetes, you shouldn't get a pancreas transplant. So that's pretty much it. I don't know if there'll be questions about chronic pancreatitis and, total pancreatectomy with auto islet. I didn't get into that because it's not really, I mean, it's transplant, but it's not really transplant. So I'm going to let that be. But really, if you don't have diabetes, you shouldn't get a pancreas transplant. Again, contraindications are essentially the same. All right, so the technical considerations of pancreas transplant are a little bit more complicated. Why is that? So 1, as we talked about, inflow and outflow. Okay, so in the pancreas and drainage. So in the pancreas, there is inflow from 2 different sources, the splenic artery and the SMA. When the pancreas allograft is procured, those 2 things aren't connected, right? One thing is connected to the celiac axis, one thing is its own axis. And so somehow you have to reconstruct that. So what you do is what we call a Y graft. So what is a Y graft? It's basically an iliac artery. The internal iliac artery is connected to the splenic artery, the external to the SMA, and then the common orifice or the common artery, iliac artery is then connected to the inflow on the one of the iliac arteries in the recipient. So that's a Y graft, all right? So you already have one complex arterial reconstruction. The venous outflow is through the portal vein, right? So the SMV, and then it comes into the pancreatic portion of the portal vein. It's a very short outflow. And the pancreas itself doesn't have a lot of portal venous drainage, right? If you think about the portal vein, it's getting blood from the mesenteric circulation, so all of the gut, plus the splenic vein. And so the overall flow through the portal vein now is much less than it was before you did a pancreas transplant. The third thing is the pancreas has exocrine secretions, which you don't necessarily need for a transplant, but you got to get rid of them somehow. And so classically, there have been 2 ways to do this. for a long time, it was done through what we call bladder drainage or cystic drainage, and I'll speak to that in a second. But now we do mostly enteric drainage. So the complications in pancreas transplantation are greater than they are in kidney transplantation, probably even greater than they are in liver transplantation when it comes to inflow, outflow, and drainage. So the vascular complications are about 5% risk of arterial thrombosis, 10% risk of venous thrombosis, and about a 5% risk of leak, enteric leak, all right, whether you do it through the bladder or the small intestine. And those can be catastrophic because if you get a thrombosis in a pancreas, basically it won't work. If you get a leak from a pancreas, it'll cause a really bad infection and then probably won't work. So the overall perioperative complication rate for pancreas transplantation is extremely high. The only question I can, so classically the question that they might ask is, you have a pancreas, you sew it in, the blood glucose is not dropping, what should you do? You should probably get an ultrasound to make sure the vessels are open. And if they're thrombosed, that's probably means that the pancreas isn't working. Another classic question would be, patient develops a fluid collection after their pancreas is hooked up to the bladder. It looks like, you drain it. It has a high amylase. What should you do to help facilitate drainage? Classically, in a bladder drained pancreas, you put in a Foley. For enteric drained pancreas, you probably leave a drain, but you probably have to revise the anastomosis as well. So, all right. So I think that's the technical considerations there. All right. Okay. So now, that's the operation. That's great. But then we have all of this other stuff that affects our graft function. And that is really the immunobiology of transplantation. And we can really divide it up into two categories. One is innate immunity, which is sort of the non-specific, non-antigen-directed component of our immune system, and adaptive immunity, which is the immunity which has specificity to antigen. All right. So innate immunity, if you take anything from these slides, two things from these slides, innate immunity is basically about ischemia reperfusion injury and non-specific graft injury that primes the adaptive immune system to cause classically what we think of as cellular or antibody-mediated rejection. That's literally, the gist of all of these slides. So if it gets confusing or overwhelming, just go back to that. So innate immunity, what contributes to innate immunity? So we have cells, but we also have receptors. And the primary receptors that contribute to the innate immune response are what we call toll-like receptors. And then complement constitutes another part of the innate immune response that's not exactly cellular. So what do toll-like receptors do? Well, toll-like receptors are pattern recognition receptors, right? So they recognize either patterns from bacteria, or they recognize patterns from cellular degradation products. So classically in transplant, it's more the latter than the former. And, toll-like receptors 2 and 9 are classically associated with transplant-induced ischemia reperfusion injury. So when, cells are damaged after ischemia reperfusion, toll-like receptors are activated. Toll-like receptors cause an inflammatory cascade. That inflammatory cascade leads to greater injury either through activation of cells and their damage control mechanism, like in neutrophils or macrophages, or causes more cells to migrate into the area of injury. All right. How does complement work? So again, don't take this, the slides are more detailed than you probably need to know. There are 3 basic pathways of complement activation. There's a classical pathway, which involves usually immunoglobulin of some sort, IgG or IgM, that binds to complement proteins, which then form the attack complex. There's a lectin pathway, which is based on sugars. And then there's an alternative pathway, which is sort of classically with bacteria and complement, components deposit on it directly and then lead to formation of the activation complex. All right. So how does complement affect the innate immune response? Well, complement is activated as part of reperfusion injury. The 2 pathways that classically are associated with reperfusion injury are the lectin alternative pathway, because antibody usually isn't present in the early reperfusion cycle. Complement causes causes damage to cells themselves, right? But it also causes more cells to migrate, usually through things like C5a or C3a. And complement itself can also upregulate the adaptive immune response by increasing the sensitivity of APCs to present antigen to T cells, and then also can enhance T cell survival. So, all right. So basically, this sort of outlines how ischemia reperfusion injury works. All right. So you have an organ that's procured, it's preserved in cold. There is some injury when it loses that blood supply and gets preserved. And then what happens is it slowly depletes its energy supply, it's deprived of oxygen, and then all of a sudden you re-expose it to oxygen without an energy supply. It now has to restart cellular respiration. It doesn't have all of the components it needs to successfully do that. That leads to lipid breakdown and peroxidation, and then damage. That damage activates toll-like receptors. Endothelium is also injured, so complement is deposited. All of those things lead to an inflammatory response and cells that migrate into the graft. And then those cells upregulate T cells, and then ultimately T cells interact with B cells to increase the adaptive immune response. And that precipitates or helps promote immune injury. All right. Okay, so adaptive immunity, we talked about it briefly. So the components of the adaptive immune system are basically T cells, B cells, and then the human leukocyte antigen loci, or more commonly referred to as major histocompatibility complex. These are the most well-studied component of biology and transplantation, and based on that fact, these are where most of the therapies or immunosuppression is based. So if you understand a little bit about the adaptive immune response and its role, it'll make it easier to understand why we use or how the drugs that are used work, and or also what they might have in terms of side effects. All right. So again, don't take this, please don't memorize what's on the slide. I just want you to get the general concept, which is that the primary driver of the adaptive immune response in transplantation is T cells. All right. So T cells are developed in the thymus. They do not develop in response to any particular organ. They are developed independently. But as it happens, that repertoire is about 10% of what we call alloreactive, meaning that the way it's developed, 10% of those cells will react to human tissues that don't look like us. And how do we know what looks like, quote unquote, us versus not us? So that is all dependent on HLA, right? So there are combinations of molecules on the surfaces of cells from two different loci of HLA, class 1 and class 2, that create combinations in which proteins are presented. And when those proteins are presented, our cells recognize whether that's us or not us. And when they think it's not us, they initiate a damage or inflammatory response. The total combinations of HLA can be in the tens to hundreds of thousands. So it's almost a unique signature each person has. All right. Not quite, because there are people who are HLA identical, but pretty close. All right. So when we're transplanting, or we're transplanting allogeneic tissue, meaning tissue from other human beings from the same species, we are faced with this barrier of HLA. All right. So how does this HLA barrier affect transplanted organs? Well, there are cells called antigen-presenting cells, which will take up pieces of HLA antigen that's been broken down from the organ, and then present it. Now, they can present it directly to a recipient T cells. So T cells could just be circulating within the graft, and all of a sudden they encounter a donor antigen-presenting cell. And why does it even matter if it's a donor? But they directly get activated. Or there's the more classic way where an antigen-presenting cell from the recipient goes through the organ, picks up foreign tissue, goes back to a lymph node, presents it to a T cell gets activated, then it goes back to the graft and causes injury, which is indirect. Both of these mechanisms lead to injury to the graft or acute cellular rejection. Direct recognition probably causes it within a few days, so 3 to 7 days. Indirect recognition probably takes up to 2 weeks. All right. But all in all, if you get acute cellular rejection and you don't treat it, you'll lose your graft. All right. And this mechanism is pretty conserved across organs. So what I'm talking about is not necessarily specific to liver, kidney, or to pancreas. All right. Now, what what happens when a T cell is activated? So a T cell, when it's activated, has three basic signals that it receives. All right. So it receives a signal through the T cell receptor, which causes it to become activated and lead to phosphorylation of various molecules. It also receives what we call a co-stimulatory signal through molecules such as CD28 or CD40 ligand. These cause other kinases to be activated. And then there's a third signal, which is not listed on here, in which IL-2 is produced and it causes a autocrine feedback loop. The basic idea is that these activating mechanisms lead to one common pathway, which is that nuclear factor of activation of T cells is dephosphorylated, allows it to move into the nucleus of the T cell and produce IL-2. IL-2, in turn, causes T cells to proliferate. So if you get a question about, what cytokine causes T cells to proliferate, it is IL-2 acting on the CD25 receptor. All right. And if you get questions about co-stimulatory molecules, it's most likely going to be CD28. So CD28 interacts with B7-1 and B7-2. CD40 ligand is on T cells and it interacts with CD40. I do not think you will get a bunch of other co-stimulatory molecule questions. You may get questions about what cells are quote unquote helper T cells or cause B cell activation, which is CD4 positive cells, and which are cytotoxic, which is CD8. So classically, we think of like direct allorecognition as being CD8 positive T cells that cause direct graft injury. All right. Now, there's another thing on here that says calcineurin, right? So we'll come back to this. This is an important component of how T cells become activated and then how we suppress their activation. Calcineurin is a phosphatase. It helps remove the phosphate off of nuclear factor of activation of T cells. So if we can inhibit calcineurin, we can inhibit the activation of T cells. All right. Okay. So B cells. B cells really don't become activated until T cells do. B cells, so a T cell may become activated, recognize that a graft is injured, then it encounters a B cell that is also presenting antigen, and it causes that B cell to become activated and then produce antibody against that graft. These antibodies are primarily produced against HLA antigens, all right, and that'll become important in a minute when we talk about the cross match, all right. So antibody-mediated rejection usually comes after cellular rejection, and we can talk a little bit about what antibody-mediated rejection looks like on a slide that might come up in one of the ABSITE questions. All right. Okay. I'll talk about this in a second. All right. So one of the things about antibodies in transplantation, I mentioned that T cells have to activate B cells to produce antibodies against human tissue. Now, usually in the vast majority of people, that doesn't happen until you're exposed to a tissue. So if you've been exposed in a transplant, then it will happen. However, there are situations where those antibodies might develop before you get exposed to a transplant. So what could those be? Well, pregnancy. So pregnancy technically is exposure to tissue that's not completely self, right? Blood transfusions, very rarely use of things like homografts. So, human tissue that's still cellularized or still may have human antigens on them, like, veins or even other human tissue. So what does that do? So think of it like a vaccine, right? So when you get a vaccine, you get exposed to antigens. Those antigens lead to your body forming an antibody response. That antibody response then gets accelerated or becomes more strong the next time you get exposed. So in some patients, about 5% of patients, they actually have antibodies against other human tissue. Now, why is that important? Well, by and large, they don't do anything helpful for us or harmful for us. But if you expose other human tissue to somebody who has these antibodies present, it's just like a vaccine response. They could cause damage right away. And so in many organs, particularly in kidney and pancreas, and then in thoracic organs, we do what's called a cross match. So what we do is we expose the foreign tissue or the donor tissue, usually donor cells, to the recipient serum, which may contain antibody, and we see if those antibodies are present through flow cytometry. And if they're present through flow cytometry, that tells us that this person has antibodies which could damage this organ right away. And so we don't want to do that, right? Because that means this organ is probably not going to work properly. And antibody-mediated rejection or antibody injury is much, much, much harder to treat than cellular injury, because we have not just only get rid of antibodies, but then we also have to try to get rid of the cells that are producing the antibodies, which is hard to do. All right, so this probably should have put at the beginning, but basically HLA constitutes, as we talked about, two different classes of antigens, class 1 and class 2. Classically, class 1 is A, B, and C, and class 2 is DP, DQ, and DR. If there's an ABSITE question about which are the most important ones, it's A, B, and DR. Those are the ones that are expressed at the highest levels and tend to constitute the ones that we're most worried about in terms of antibody production too. All right, so I don't recall there being questions like that, but just so you know. All right, okay, and then class 1 MHC is associated with CD8 cells, class 2 is associated with CD4. And class 1 is expressed universally. Class 2 is expressed primarily on antigen-presenting cells, such as B cells or macrophages or professional antigen-presenting cells, and can be induced. So, okay, so putting it all together, transplant occurs across different major histocompatibility complexes in humans, i.e. allogeneic transplantation. Transplant organs need to be procured, resulting in ischemia-reperfusion injury. Ischemia-reperfusion injury induces direct innate immune system-mediated organ damage and then primes the adaptive immune response. The adaptive immune response is T cells and B cells. Activated T cells called acute cellular injury. Activated B cells at some point cause antibody-mediated injury. Immune injury is a primary contributor to early and then late graft loss. All right, so these are the different types of rejection. So it's just the same thing I said on the side just before. So these are questions that might come across. So they may tell you about a rejection that happens. You put an organ in and all of a sudden everything looks black and it's thrombosed and necrotic. So that's what we call hyperacute rejection. It happens within minutes to or hours. Usually because of ABO incompatibility. So those are not IgG antibodies. Those are usually, I think, IgM antibodies. Or preformed anti-HLA antibodies, which we talked about, right? So that's why cross-match is important. Acute cellular rejection is, as it says, caused by T cells and usually happens within 3 to 7 days. The pathology that you'll see is usually in the bile duct or in the liver, you'll see portal inflammation, some bile duct inflammation. In the liver, in the kidney, you'll see tubular inflammation. Acute antibody rejection or humoral rejection usually takes a little bit longer. It's again caused by anti-donor antibodies, but usually not right away. And this usually is what we call vascular rejection. Classically, the lesion is capillaritis. All right, so capillary inflammation. And then there's chronic rejection. So chronic rejection is sort of a grab bag of chronic changes. And I'll put on another slide, I'll elucidate the pathology. All right, so this is the other slide. So what do we talk about when we're talking about chronic rejection in let's say a kidney? It's called interstitial fibrosis or tubular atrophy. There's lots of scarring, right? In the liver, it's classically called ductopenic rejection, meaning that there are vanishing bile ducts with scarring. In the heart and lung, which I don't know if they'll ask you, in the heart, it's called chronic cardiac allograft vasculopathy, so the coronary arteries look diffusely injured. And in the lungs, it's called bronchiolitis obliterans and organizing pneumonia. All right. So what causes chronic injury? So it's a combination of antibody-mediated rejection, chronic vascular changes, and infections, which cause injury to the graft, like CMV, in a variety of organs such as lung, kidney, even liver, to some degree pancreas, and then BK virus, which is a polyoma virus specifically affecting the kidney. All right, we talked about sensitization. Okay, so how do we address this? So this is immunosuppression, right? So immunosuppression is divided up into two basic categories, and I know I have a few minutes left, so hopefully I don't have too many more slides. Either we get rid of the cells, so that's called depletion. We inactivate the cells up front, or we use steroids, which kind of globally suppress the immune system. So that's induction immunotherapy. Maintenance is all about then specifically inhibiting usually T cells and to some degree B cells. And that includes things like calcineurin inhibitors, antimetabolites, mTOR, and then co-stimulation blockade. All right. So again, you don't have to memorize or take everything in the slide. But the bottom line is that when we use these medicines, we're trying to achieve a specific effect, right? So the first one is, hey, let's just get rid of all the cells that could potentially cause problems. What are the cells most likely to cause problems? T cells. So why don't we use antibodies that help deplete T cells? So there are two different antibodies that deplete T cells. One is a polyclonal antibody called antithymocyte globulin, usually from a rabbit or horse. It causes cells to be depleted, but it does have side effects. So it can cause those same cells to be activated and cause cytokine storm, thrombocytopenia, or even serum sickness, where if we use too much foreign antibody, it gets deposited, causes joint pain. Another antibody is called alemtuzumab, which is anti-CD52, and it basically depletes everything, including T and B cells, and it causes severe leukopenia. All right. There are non-depleting antibodies. So what do these do? Well, these just cover up the high affinity IL-2 receptor and just prevent T cells from becoming activated. They are not as strong, so there may be more rejection associated with them, but they have fewer side effects. And then steroids just globally suppress cytokine production. And if they ask you which cytokine, classically it's IL-1. All right, what about maintenance? So we talked about activation of T cells, right? So what if they escape this depletion? How do we keep them from becoming activated? I remember that thing calcineurin, which helps remove the phosphate. So there are a couple of categories of drugs called calcineurin inhibitors. And the classic ones are cyclosporin and tacrolimus. Cyclosporin binds cyclosporin binding protein, tacrolimus binds FK binding protein. And what they do is they prevent calcineurin from becoming activated. And because calcineurin doesn't become activated, nuclear factor activation of T cells doesn't get into the nucleus. All right. What if they escape that? Well, then we have medicines that prevent the cells from dividing. These are called antiproliferatives. The classic one is mycophenolate mofetil, which utilizes inhibition of the purine salvage pathway to prevent cells from incorporating T cells and B cells from incorporating DNA and dividing. All right. When the classic side effects are leukopenia, if you don't use MMF, you're at higher risk for antibody-mediated rejection. There is another antiproliferative, which is older, called azathioprine, and it involves inhibition of 6-mercaptopurine. Finally, if you escape all of those things, there's a third class of drugs called rapamycin, or molecular targets of rapamycin. These work by basically stopping signaling through the high-affinity IL-2 receptor, CD25, and basically inhibit molecular target of rapamycin, which in turn causes cells to stop moving through the cell cycle. It's classically associated with problems with wound healing. So if you get a question about what's the major side effect of rapamycin or mTOR, it's that people develop hernias and have poor wound healing. All right. The last class of drugs is co-stimulation blockade. So we talked about briefly CD28. So there is a molecule called CTLA-4, which interacts with the same co-stimulatory molecules as CD28. So if you have a drug that has CTLA-4 on it and covers up the other molecules that CD28 needs to become activated, then T cells won't become activated. All right. So this is sort of a schema of all of these things. It's just a table that kind of summarizes exactly what I said. And I just want to focus on the calcineurin inhibitors and their side effects, which is that for tacrolimus, it's nephrotoxicity, tremors, and seizures. For cyclosporin, it's classically gingival hyperplasia, hirsutism. And then for the MMF, it's GI side effects and leukopenia. Azathioprine, we don't really use much anymore, but if they ask about it, pancreatitis and increased skin malignancies. And then mTOR is impaired wound healing, you see down there. So, all right. So what are the other complications of immunosuppression? Basically infections. These are opportunistic infections. Classically, we talk about PCP, which doesn't come up very often anymore, is treated with Bactrim. And then viral reactivation diseases, which are Epstein-Barr virus, cytomegalovirus, and in kidney transplantation, BK virus. Malignancy. So malignancy overall can be increased in post-transplant patients. However, classically, the two associated malignancies are non-melanoma skin cancers, so basal cell carcinoma of the skin or squamous cell carcinoma of the skin, and hematologic malignancies, specifically post-transplant lymphoproliferative disorder. So if you get a question about somebody who has a bunch of lymph nodes post-transplant and they, which virus is associated with it, that's Epstein-Barr virus. So post-transplant lymphoproliferative disorder can be polyclonal, or it can be monoclonal, which is like a true B-cell lymphoma. All right. So that's really the overview of transplantation. I'm sure there's more material out there. I just, wanted to focus on, things that I thought might be on the ABSITE. So I know I only have a few minutes left, but if you guys have any questions or concerns, please don't hesitate to ask.
Thank you, Ladar. So one of the questions the participant asks is, how do you decide between which of the three methods of urethral implantation to perform?
Oh, I would say that the lich is the most likely one, because it is the easiest technically to do and still has an incredibly low leak and stricture rate. And the reason is that you only have to make an anterior opening in the bladder. You don't need as much length of the ureter. You spatulate the ureter, so you still provide yourself, a lower risk of developing a stricture. And then you put a muscular tunnel back over the ureter or the ureteral anastomosis to create something like a reflux valve. The Ledbetter Politano, the problem with it is that it's a very good way to do it, but you need to open the bladder anteriorly and then tunnel the ureter into the bladder. And that would require larger length of ureter, as well as, a bladder that's not super small. So if you have a really small bladder and you make a big cystotomy in it, it becomes a challenge to then close it and then, tunnel the ureter. I never use the one stitch technique. Very, very few people use the one stitch technique. It is associated with at least a 3 to 4 times increased risk of leak. So the leak rate goes from maybe 1% or less to 5 to 7%. So the one stitch is really not the standard of care.